This conference will now be recorded.
Good evening, everyone. This is Rick Davis, and I am leading tonight from deep southern Arizona, 20 miles north of the border in Tubac. And I have to give a quick shout out to our sponsors, who are Bayer, Pfizer, Janssen, Myriad, Myriad Genetics, that is, Myovant, Telix, who makes one of the PSMA scans, and Foundation Medicine, who you're all familiar with, or most of you are familiar with, who is one of the providers of the sequencing. And I think we've had some success with them. We've been advocating with them this past week. They didn't want to listen to us, and they didn't want to listen to some of the best doctors in the world. But thank goodness the FDA was smart enough to listen to us, and they met on Friday. And as we pointed out, it's a very loose we. It's really Len. It's not really me. I was just sort of the go-between. But as Len pointed out to them back in 2020, all of those homologous recombination repair genes like ATM and CHEK2 and CDK and all of the rest of them except for BRCA are not don't respond to olaparib. And we asked them to stop putting it on their reports, because certain men, and it happened to Tony Figg a couple of weeks ago, they get all excited about, oh, I've got something that's actionable, and it ain't really actionable. And we've been trying to get them to take it off, because we see it not just as a medical issue, but as a mental health issue. We didn't have the success we wanted, but we kept hammering away. And hopefully, as a result of this FDA meeting, ODCA, I think it's called. What does ODCA stand for, Len?
Oncology Drugs Advisory Committee, ODAC.
ODAC, I was close. They met on Friday and they agreed with our position. So now we are going to see what FMI does. You know, it's a bit of a conflict of interest, which I've actually pointed out to the CEO, because the more actionable drugs, more actionable mutations they show, the more attractive is their product. And, you know, but we don't want them showing stuff that's actionable that really isn't. Anyway, enough of that. We're going to move to Mr. Lindsay here. Lynn has been here by reputation before, because his brother has referred to him. This is the older brother, and if I'm not mistaken, you've been living with more advanced prostate cancer for a while. So what I'm going to do is ask you a few questions, if I may, Lynn, and then we'll give you some time to respond. So how old are you?
76.
And where do you live?
In the suburb of the Twin Cities, suburb of St. Paul, Minnesota.
Okay. Excellent. You'll have the opportunity maybe to meet Mr. Kafka when he's there, as he usually is for the summer months. I have to think about this. It's the summer months he's there. He gets that. He's in Maui for the winter. Now, what year were you first diagnosed?
In I think it was June of 2009.
Okay, well, that's pretty good. And at the time of that diagnosis, what was your Gleason score and your PSA level?
Gleason was 4 plus 5, and the PSA was 6.0.
you've already got these guys' attention because 14 years ago you had a 4+5 and you sound in very good shape. So I'm
Well,
sure everybody wants to know what the secret is. Where did you first go for treatment and which institution?
so I went to Mayo
What doc?
Clinic, and I had a
Right.
urologist whose name is Matthew Getman, um, provide me with the Da Vinci robotic prostatectomy.
Ooh, you were one of the first.
Yes.
Not exactly, but I know because I was diagnosed in late 2007, and in 2008, when I was talking treatment, my doc was still using laparoscopic instruments and he wasn't comfortable enough doing the robot yet.
Right.
So that's how I know. And then in the end, I decided to go for radiation. And anyway, so you had Da Vinci in 2009,
Right.
and did they, with a 4+5, they must have done some scanning. Did they see anything?
Well, you say scanning, you mean, are you talking about before or after? Would have been after, I'm thinking.
Before,
I don't,
before with a 4+5, they should have done a bone scan, at least a bone scan and a CT scan.
I don't think they did. This was
Well,
quite some
that
time
even
ago.
that,
Mm-mm.
that was standard of practice even back then. If you had a 4 in your number, they were supposed to do a bone scan and a CT scan. But you
You know,
don't
they
think
might
they
have
did?
done a bone, they might have done a bone scan, but if they did, I didn't really capture the information in my notes. I might have, but
Okay. So tell us what happened after this 2009 Da Vinci.
well, so I'll give you what I'll call the numbers or the acronyms. So it was a PT3A, an N0, and an MX. But my understanding was they found extra prostatic, I'm reading, extension and perineural invasion.
Right,
They found nothing, as I recall, uh, in the lymph nodes. There was lymph nodes were clear.
right. And was it in the seminal? Was it T3A? So that, if my memory serves me right, that means it was not in the seminal vesicles. I think that's T3B.
I can't comment on that, Rick. I'm sorry. Sorry.
So you okay, but I think it wasn't. It
Yeah,
wasn't.
that's
Seminal
true.
ves.
T3
Say that again, Len.
T3A is no SVI.
Yeah, T3A is no SVI. Yeah, I was T3A. Yeah, yeah. Thank you. Um, so what happened after
So
this? Take us
the
through what.
the PSA went really undetectable for about 6 years. Uh, Mayo, as I recall, if it gets down to 0.10, that's what at that time Mayo called undetectable. And for my
Right,
part, the PSA, whenever it was, every 3 months or 6 months, bounced around a lot. It would go up a little bit, down a little bit, but just sort of skimmed the surface of detectability for 6 years.
okay. So for
Then,
6 years, you were right around that point one level, and then what
right.
happened?
Well, it started rising in 2014 and 15.
Yeah,
Uh, the Mayo did an MRI of my prostate, um, but it was rising just enough. As I recall, in May of 2000, I'm reading from my own notes. In May of 2015, the PSA hiked from uh, from 0.14 in the October of 2014 to a 0.24. Sorry, 0.14 to 0.24. It was at that time that I was referred by the urologist side of Mayo to the radiation oncologist, to an radiation oncology department, where the fellow's name is Brian Davis, is their radiation oncologist who I've been seeing.
mm-hmm.
And at that time, in July, late July of 2015, I underwent 33 fractions of what amounted to be 6,600 gray. I'm tossing about expressions that I really don't have a lot of understanding of. I'm just, again, reading my notes. To the area called the prostatic fossa.
Yeah.
And then the PSA went down to its lowest, 0.11. And thereafter, it just sort of stayed there for a time. I'm sorry, I do not have the respective readings. It stayed there for a long time. It gradually rose, and they gave me a PET choline, whatever that is, on February of 2019. They didn't find much, but when I said they didn't find much, they said, well, we'll eventually here we'll give you a biopsy, and we'll probably give you some more external beam radiation when the tumors grew large enough really to see. All right. So I went to the U of M at that point, and quite frankly, the PSA rose to 15.4
Wow.
when the U of M, under the guidance of Stuart Bloom at the U of M,
Ooh, we know him.
gave me a PSMA. Now, I don't know if this is meaningful or not. So F-18. My understanding is, Rick, I listened to you some of the tapes from earlier meetings, and apparently there's more than one kind of PSMA, but this said F-18 PSMA.
Yeah, F18 is not a PSMA scan.
Aha.
Is it? Wait a minute. What am I? Hold on a minute.
That's Polarify, Rick.
Yeah, Pylarify. It is. Of course it is. Yes, Pylarify. Yes, it is. Excuse me. Go
Okay.
ahead.
So that was
Yes.
in January of 2022. And I'll read you what the radiologist or what the analyst said about what the images are. And I found them a little on the gobbledygook side, but basically what they found are that's TWO, 2 sub-centimeter tumors, that's my word, one to the pelvis, one to the abdomen. And specifically, it said uptake just, G-A-U-S-T, medial to the right ureter. And the second tumor was, it said uptake in the left anterior lateral mesentery adjacent to the transverse colon and superior jejunum, which to me means intestines. But that's what I say. I have no idea what it is.
So these were both soft tissue. Both of
Yes,
these were soft
correct.
tissue.
That's correct. Now, of interest, at that time, Dr. Bloom, who said that he had conferred with two of his colleagues, stated that that the U of M declined or would not radiate me to excise or kill these tumors. And in layman's terms, my terms, I understood him to mean that the radiotherapy could not focus on my bouncing belly. I mean, he said we can't focus enough to get those tumors. Is basically what he said. He said at that point, he said you'll have to go to ADT, and that's all really we have to offer you. I hope I've captured what he said to me.
Mm-hmm.
So at that point, I went back to Mayo, and that Mayo in June of last year, I began taking Firmagon. The Firmagon, the PSA at that time, bear with me, the Firmagon really did knock everything down, the PSA readings. I think it went from, it went down from 11.3 in June of 2022 to 0.9 on July of 2022, where it held for a long time. Every 90 days, I would get a PSA test, and there was no reintroduction of Firmagon. I had just two little shots. I think it said 40 in total, however they measure the units, 40 ml, 40 something. That's what they gave me last June. It went so that the PSA and obviously my testosterone together went very, very low and really undetectable.
So let me just jump in here
Yes,
because
I'm sorry, please. Yeah,
I'm getting a little bit confused. I mean, back
please.
in 2019, your PSA was at 15.4,
Correct.
right? And
Yep.
then Stuart Bloom said, we can't do radiation. And that was in 20. I mean, when you first went over to see Stuart Bloom and it was
Yes.
15.4,
Right.
what did he do? Nothing? He just let it, he didn't give you hormone therapy at that point, and he said he didn't give you a Pylarify, a PYL DCF until 2022. So what happened between 2019 and 2022?
I was visiting with Stuart Bloom before he went from his private practice position to the U of M.
Right.
And what we talked about is whether I would take Casodex or Lupron.
Yeah.
And I deferred for a long time. And then I went to see him at the U of M,
So from
where
2019 to 2022, essentially, you declined any hormone therapy.
that's correct.
Okay. And okay. And then you were at 15.4 and you did this. Now, somehow or other, you went from 15.4 down to 11.3 before you got your first Pharmagon shot.
Yes, and I can explain that to best of my recollection. As I was reading the numbers, I too was wondering how did I go from 15.4 to 11.2 before the first Firmagon. Interestingly enough, I think it's interesting, the U of M's calibration or its assay had different numbers than what Mayo has. I don't know if that makes sense to you. So
It
when
does.
Mayo gave me its PSA reading, and it looked at what the U of M had pushed out as my rating. The doctor at Mayo said none of us could understand why would it go from 15.4, as I recall, to 11. And all the doctor at Mayo said was, well, they have a different assay, a different calibration, a different machine. We can't explain it. Does that
Well,
make sense to you at all?
well, it sort of makes sense. I mean, there is a difference in the calibration. I don't know how much it is. I think Joe Gallo, who recently came on, he knows a lot about the calibration, but it certainly shouldn't be a 33% difference.
I
I mean,
agree with that. I agree with that.
uh,
And I do remember vividly, well, as vividly as I can be, the conversation I had with the U of M, I'm sorry, with Mayo, and how surprised the oncologist was about why would the reading be so different. And I didn't know what to make of it either.
yeah, I don't know. I mean, the other remarkable thing that I see right now with 4+5, when you got your radiation back in 2015, they only radiated the prostate bed. I mean, it's like beyond me how a man who has recurrence and a 4+5, fossa means bed. So all they did is they radiated the prostate bed. They didn't radiate the whole pelvic girdle. And, the result of that, um, you were still dealing with more recurrence back in 2022. Now, that's not to say you wouldn't have had it, but if they would have treated you in a more conventional fashion, which would have been the full bed and additional hormone therapy at that time, you might not be. There's a good chance you wouldn't be dealing with what you are now. So now we're now in 2023. Who is your quarterback doctor right now?
Well, the quarterback is, in fact, still this radiation oncologist to whom I returned, a fellow
Right.
Brian Davis.
And
Uh,
and and he's the guy that didn't radiate your whole pelvic girdle, and he didn't put you on hormone therapy back in 2015, right?
That's true. And thank you very much for raising the difference between pelvic girdle and prostate bed. That was actually one of my questions. I had listened to one of your earlier tapes that I looked at just in the last few days, and it occurred to me, gee whiz, I wonder if girdle is a little higher in the body than just the prostate bed. But I can confirm that in fact in those days back in 2015, I'm just sure it was just the prostate bed. I'm sure of it.
Okay.
And I was even
Now,
unaware until recently that there was a pelvic
right.
girdle.
Now, Lynn, did Davis agree to radiate these two soft tissue lesions that were seen with the PSMA scan?
I'll give you a direct, almost direct quote. He was, what he said was, he said that his analyst, his radiologist, whoever reads the images that the U of M had produced at Mayo, really could not square, that analyst at Mayo could not square his analysis with what he was reading from the U of M. A. And that B, he said, and when I told him that the U of M had said no, the U of M declined to radiate me to kill these two cancers, uh, the radiation oncologist at Mayo said, effectively, he said, I hate to quote him on account, he said, well, we've never seen a tumor we can't get to. In other words,
Okay. So are they
yes.
I'm in the interest of time, I need
Yeah, I'm
to
sorry. I'm
hurry you
sorry.
on.
Sorry.
Are
Sorry.
they radiating this? Are they going to radiate these? Have they radiated
No,
these
I'm
two?
going down on this coming week to get a PET CT scan and MR prostate picture uh, within a week or so.
Okay. And do they plan to radiate? They plan to do spot radiation, or are they going to radiate the whole pelvic girdle this time?
That is unclear. We haven't had that meeting. I'll have a meeting with this doctor after he gets the results of these pictures.
Okay. So we don't know. Do you know what type of radiation you're getting at Mayo, and how they're going to go after this or not?
No.
Okay. Well, here's what I would do if it were me. I would have all your records immediately transferred to Dr. Oliver Sartor, and I would ask Dr. Sartor what the hell's going on. I don't think I've gotten very good treatment to date for the last 14 years. And before you do anything, move your treatment, move your quarterback to Dr. Sartor, have a discussion with him, and go from there. I would cancel everything and go and see Dr. Sartor, who started at Mayo on April the 1st.
Do you know
Mayo
what?
has its own way of doing things.
Is he
And
in radiation?
sadly, my experience has been that when it comes to advanced prostate cancer, there are too many questionable decisions. I'm trying to be diplomatic. Now, Dr. Sartor is one of the best genitourinary medical oncologists in the country. He was one of the people, by the way, who signed this paper about the olaparib stuff that I was talking right at the beginning. And I think one of the reasons they've hired him is to try and sort out why they have difficulty in treating men with advanced prostate cancer. So you go in there without a medical oncologist. Brian Davis is your radiation oncologist. Brian Davis may be used to treating advanced men, but he shouldn't be doing it. That's the bailiwick of in our view, in ANCAN's view, and in the view of most, I think, advocates and doctors, and that's the bailiwick of a genitourinary medical oncologist. And so if I were you, I'd call him up tomorrow morning, and you'd say, I'm supposed to be coming up next week. I'd like to defer that appointment and combine it with an appointment with Dr. Sartor. I'd like Dr. Sartor to look at my records, and I'd like to confer with Dr. Sartor as what I should do next.
Sartor is with Mayo?
He started on April 1st.
I see.
He came from Tulane.
Got it. Well, you've
Okay.
answered. Yes, thank you. Had a couple of
And with
questions.
that, I'm going to throw it open in the interest of time, and we've still got one other new guy. I'm going to throw it open to the group to ask you any questions. And if you will let the group ask you, and then if you have any questions, you can ask the group. So
Thank you.
anybody have anything they'd like
Lynn,
to ask?
this is Peter Kafka, and I know your brother, and
Yes.
I know he had genetic testing that came back as nothing actionable. Has anybody done genetic or genomic testing with you?
No, however, that is one of my no. My
Okay,
question was the difference between.
you want to ask for that. That's a priority because even though Chick doesn't seem to have anything, the fact that your two brothers with this disease, it's a you want to get tested, both germline and somatic, and find out what's going on here. Uh,
Thank you,
because
Peter. Great
you've
point.
got some odd stuff going on. You've got disease in an odd place, just like I do in your abdomen, and not many men get stuff going on there, and it might need to be biopsied to find out what it really is.
Right. Thank you.
Great point, Peter. Thank you so much. I missed that. And yes, you definitely need. In fact, they should have done genetic testing. Dr. Bloom should have done it because the NCCN guidelines were there. Dr. Davis should have done it because the NCCN guidelines were there, at least the germline, if not the somatic. The difference is the germline is what you inherit. The somatic is what you make in your own body.
Got it.
Thank you, Peter. Anyone else? Anything they'd like to say?
Is this someone who'd be a good candidate for the Meridian technology in addressing the tumors? Because I heard where he said that, well, they were, your abdomen moves and that's the whole thing with Meridian. If there's movement, the beam stops.
Maybe. I mean, I don't know enough about ViewRay. Peter, let me hand that one back to you because you've been studying ViewRay amongst all of us here. I think you've been studying it more than anybody else in the last 4 weeks.
Yeah, I mean, ViewRay would probably be effective. I know it's at Henry Ford in Detroit, and I think one other place in the Midwest. But until you really know what's going on and what's driving this, I mean, I don't think this doesn't sound like a whack-a-mole type of situation. When you got something going on in your abdomen like that, that's not really specific and defined. Um, I would get more information. I think going with Dr. Sartor first is a good move, or even Dr. Antanarakis if it's easier. Whatever's most convenient for you.
Well, the problem with Dr. Antanarakis is it means that Lynn's got to switch from Bloom to Antanarakis, and I don't know how easy that is at Masonic.
Agreed.
So that's why I didn't suggest him, because sometimes when you try to switch between docs in the same department, you can run into problems, Peter.
Right.
Got it. Understand.
Whereas
I wouldn't start looking for radiation machines yet. I would get a quarterback and really drill down and find out what's actually going on.
That's right. You see, the problem with Dr. Davis Dr. Davis thinks radiation. And so he's going to be biased towards radiation and talk to you about this radiation machine and that one, and we can do a PBRT, but we can do SBRT, but we can do this. But no, you haven't had a lot of hormone therapy. You have 4+5. You need a proper quarterback to plot out where you're going, and you've never had that. I mean, Bloom should have done it. I mean, we know Bloom from Rob Baniscus, God rest his soul.
Yes.
My co-founder, who this room is named after, because Stuart Bloom was Rob's medical oncologist. But I don't. I also have trouble when a doctor allows you to run all the way up to 15.4 with 4+5 disease.
Yeah.
I mean, I find that a little strange. What can
Yeah.
I say? But I think that Sartor will. He's a larger than life figure. He's not like Dr. Antanarakis, I want to tell you. So, expect a big ego, big personality guy, but he's really good.
Well, quick question, Rick. You talked earlier about how Antanarakis and Bloom is not cool about moving between doctors in the same institution. Should I assume that Sartor will get along with? Will be able to coordinate with the radiation oncologist if I switch from one to the
Well,
other?
let me just say this. When I said to Dr. I saw Sartor at GU ASCO, and I saw some other famous people from Mayo at GU ASCO, and I kind of asked him, I said, are you going in with a hard hat? And he said, I've got my hard hat. I know what I'm getting myself into, and I'm going to sort it out. So my guess is that you're going to be okay. The problem at Mayo is that they don't use, and they never have used, their own medical oncologists to run advanced disease. They don't have them. They even send people out for chemo. And what they're doing now is they're bringing in an expert, a recognized, internationally recognized expert. And he's going in to treat people like you. Now, you've never had a GU medonc, so there should be no pushback from Dr. Davis. If there is, go to your patient navigator and say, this is who I want to see. And if you cannot get anywhere, let us know, and we'll see if we can backdoor it to Dr. Sartor, which we may be able to do, and let him know that you can't get to him. But I don't think you're going to have a problem. That's my guess.
That's fine. I'll Google the fellow's name. Rick, is that something you could send me or give me the spelling of his name right now or push it in there?
Sartor. Somebody will put, I don't know if he's listed yet at Mayo, but I've only got, I've got his background. I can give you his background at his profile from Tulane. Or one of the other guys can put it in the chat. It's kind of hard. Maybe Ben, could you put Dr. Sartor, even if it's only Tulane? Would you be kind enough to put that in the chat window for Lynn? And like I say, I don't know whether you could switch to Dr. Antanarakis. I just don't know how easy it is at Masonic to do that. We've never had anybody who's wanted to do it. Some institutions you can do it. Others, like Memorial Sloan Kettering, it's almost impossible.
Thank you. Just in passing, I'll mention that when I went to the urologist who excised my tumor back in 2009, I remember when the oncologist said, someday he said to me, you'll have to choose between the two of us, between the urology department and the radiation department. And so there was some jealously guarded ground.
Well, there is, and it's worse than that. But let me ask you, do you have any other questions?
No, thank you very much. Thanks so much for your time.
It's a pleasure.
Thank you very much.
It's a pleasure, and thanks to Joe Commander for putting it. It's in the chat window for you now, and he's put in a Wikipedia entry. So you're with good people, and if you cannot get to Sartor at Mayo, let us know, because he's got an uphill battle, I think, in getting internal referrals. I think he's going to find it difficult, but he knows what he's getting himself into, because he told me so. So what more can I say? I'm just trying to be as diplomatic. I don't know what Ben just put something interesting in there.
It turns out not to be totally relevant. This was a note that he wrote to his former patients.
Got it. If I can just add one more thing, and that is that The only concern I would have about Sartor, never having heard his name before now, is that sometimes it takes time for a doctor in a new institution to learn all the protocols of the new institution that he's gone into. So I'll hope as Sartor
Yeah, but
figures out.
that's not your concern. Your concern is to get the best treatment.
Agreed. Right.
And he's going to talk to you. Yes, he may not know the ins and the outs, but he's going to make sure you get the best treatment. It's not
Agreed.
about the institution, it's about the doctor. The problem with Mayo is it's always about the institution, oftentimes. And then you don't get, and because it's about the institution, you don't get the best care. So these are my opinion. And by the way, do you know how to use the chat window, Lynn?
No, as a matter of fact, I don't. I
Okay.
do not, as a
So there
matter
are
of fact.
there's a lot of information for you in the chat window. There are two little squares on the top right,
Yes,
and you click on those, it'll open a window, and there's a lot of messages in there for you.
got it. Thank you. I see
Okay?
it now. Thank you so much. Thank you.
Okay. And I'm going to move along. I'm going to let Peter talk to Mr. Wolf.
Hey, Al, are you there? Alfred? Your mic might not be on. Alfred?
Do
Okay,
we
now I got
see?
it on.
Okay.
And now I got the camera on. Yeah? You can hear me and see me?
You can. So
All
yeah, so
right.
Al was on a couple of months ago. He lives here in Maui. He's a Kaiser patient, and he has a young general medical oncologist there, and he is he's one of those guys that he's was diagnosed de novo metastatic, so he's never had a biopsy, no Gleason score, nothing of that nature. Um, but he is a advanced guy, and he's currently on Lupron and abiraterone, is it?
No, yeah, abiraterone
Yeah,
and prednisone.
abiraterone and Lupron. He's been on for several months now or so, and yeah, I'll let him. So that's where he is. I'll let him describe any more. He does. We had we kind of met casually a couple of weeks ago. He's not in any great pain or the throes of any terrible side effects at the moment. Just mostly fatigue, if anything. Um, and he tries to stay as active as possible. Um,
Mhm.
but in my opinion, he doesn't have the best care here on Maui. But what what can we do? I mean, that's when you're stuck with Kaiser, that's what you got. And so anyway, that's what's going on.
Okay,
How
I
old
have a
are you?
question.
How old are you, Al?
77.
77.
77.
Okay, go ahead.
Okay. I'm wondering with the abiraterone tablets of 4 every day sort of thing, that kind of looks like a one size fits all prescription. Do they ever vary that or change that?
So you're talking about abiraterone, right?
Yes.
Okay, we're going to call it Abby to make it easy for
Okay.
you and to make it easy for me. Okay?
Sure.
Um, the answer is not really. So the dose of 1,000, but yes and no. The dose of 1,000 milligrams is the normal dose. However, you can also take that dose in a different way. Instead of taking 1,000 milligrams an hour or so before you eat and everything else, you can take it with food, in which case you only need to take 250 and you take it with a low-fat diet and it processes through your liver. And because it does that, the potency is increased. So 250 is equivalent to 1,000. Now, that said, the other tweak that we see sometimes is that men who are having some difficulty, they are cut back. And we've seen guys cut back to 750, even to very occasionally 500, but it's not very often. And some guys will remain on 750. Some guys they will put back up, but they'll watch you at 750. The problem is that if you've got a general medical oncologist on Maui, they're not going to know these nuances. What you need to do is the following, and I think Peter probably told you this before. You need to get onto the books of Andrea Hartstock. Somebody will put her in the chat window for you. Andrea Hartstock, Harzstark. She is a Kaiser Permanente urinary medical oncologist who works out of San Francisco area. I think she's recently moved from Oakland to Geary, I think. She's very experienced. Not only is she experienced, but she, I think, was involved in the original power trials for abiraterone back around 2010 to 2012, when they were trying to figure out whether more made sense, whether you should be on 1,000, 2,000, 3,000. She's very, very familiar with abiraterone. And between your doctors, if you feel that you need to adjust your abiraterone dose, she's going to be a good counselor for your doctor to talk to.
Okay. Great. I've also read that medical marijuana can be helpful for killing cancer. Do you have
Okay,
any
so
information?
let's stop there for a moment. Is there anybody who would like to speak to Al about abiraterone and abiraterone potency?
I just had a quick question. What would drive you towards thinking of changing the 1,000 milligram standard dosage? What's the problem?
So I can tell you that I've twice tried to get up to 1,000, and my bilirubin shoots up, and so I'm back down to 750. And my doctor's she said, several patients who 750 works fine. When they try 1,000, they have problems with the liver. So that would be a reason.
Mm-hmm.
Okay,
Thank you, Dr. Bob.
I don't have those reasons. I'm just feeling the side effects of the fatigue and so forth, and I'm not a believer in one size fits all. So I'm wondering, is there a variation out there?
Well, there's two variations. I think what you're feeling, the fatigue that you're feeling, is not going to make any difference whether you're on 750 or 1,000. That's not going to. The solution to that is not reducing the abiraterone dose. The hormone therapy is what's doing that. And there are people, and we've known several of them, who have tried abiraterone as a monotherapy, meaning they don't take the Lupron, they only take the abiraterone. It's not proven, trialed, but we've seen it work anecdotally. The men tend to feel a little better. If you could discuss monotherapy abiraterone, for sure. But I think that Peter knows better than anybody about the fatigue with hormone therapy. How much exercise are you doing, Al?
I'm doing a fair amount of exercise. I work out in my garden. I walk some. I trim trees. I'm still fairly active.
How much real exercise in the gym, getting your heart rate up into the area of like 90 to 120 for 30 minutes constantly?
No,
How much weight exercise are you doing?
mostly just using my tools. I haven't used
Right.
pounds per se.
So the
Yeah.
first thing you want to do, and Peter, I know you'll help him. It is not when men come in and say, well, I'm doing the gardening, or I go for a walk in the morning. The walk only helps you if you get your heart rate elevated. And in your case, 77 from 220 minus 77 is 151.43. So you need to get your heart rate over, what's 80% of 143? About 112, right? 8 yes. So you need to get your heart rate up into that area
Okay.
of 80% of your max, and sort of hold it there, and that's going to make the difference. Same thing with weights. You've got to do resistance exercise 2 or 3 times a week. Now, anybody want to talk to? Let's move on from the Abbey for a second. Who would like to talk to Al with peer experience about the importance of exercise, both resistance and aerobic, when you're on strong hormone therapy? Who wants to speak first? Jim B.
Hi. I was just on the abiraterone. In my case, once I did fail the abiraterone, my next choice was chemotherapy because I'd already been on enzalutamide, and then I failed that, failed the abiraterone, and the next treatment in the standard of care is really chemotherapy. Correct me if I'm wrong. I don't know enough
Right, but
particulars
we're
about the
not. But
situation.
yes, but it's not really pertinent to the question, because we
I was
don't
just
think the
saying.
abiraterone is what is causing the fatigue. We think it. I mean, we think it is causing the fatigue, but not the amount of the dose. Who wants to talk about exercise? Anybody?
I do.
Okay, Jimmy G.
My direct experience is that, I just educated myself enough on the front end with a tiny bit of help from the doctors, what I consider not enough help, that very simply sarcopenia, which is the simultaneous loss of muscle mass and gain of fat around the middle, is an inevitable result of hormone therapy without strong intervention, and the fatigue that you feel, especially from the hormone therapy, as the testosterone suppression wasting the muscles, and it can be directly countered with weight training. The hardest thing about this is that the cardiovascular exercise is so important for your heart health, and the weight training is so important to prevent the muscle loss. They both have to be done. It takes a lot of effort, takes a lot of time out of your day. You feel sometimes like you're too tired to do it, but your life is transformed if you do it in a positive way. And if you don't do it, I don't know how you'd want to go through it.
Thank you, Jimmy. Chick,
Yeah,
you have your
I just
hand raised, and Cliff had his hand raised. So we're going to go to Chick and then to Cliff. Chick, go ahead.
Yeah, I think that my experience with the radiation treatments, along with I had Eligard, and I had 2 shots of Eligard over separated by 3 months each, and the exercise was just wonderful. I mean, made all the difference. My wife at first was dragging me to the swimming pool, but it became easier and easier to do 2-3 times a week. And then I have a crew of guys I play tennis with regularly. And that was, a lot of aerobic activity that again, kept me feeling, it just was wonderful. And then lots of walking. And I remember hearing on ANCAN here, a fellow, I don't know who it was, but this would be about a year and a half ago, who had gone to a conference, and he did a nice report out about what he had learned at Dana-Farber about exercise and then being on the hormone treatment. But no question that the exercise, I feel, was a huge factor in just, dealing with, some fatigue. Finally now the hormone has worn off. You didn't have any weight gain, right? Yeah, it's true. My wife reminds me, I really didn't have any weight gain. If anything, I had weight loss. But
Right. So
anyway.
let me keep moving here. Thank
Yeah.
you, Chick. Cliff, you wanted to say something.
Yes, I've been a long distance cyclist for about 20 years. And when they put me on abiraterone and Lupron, I basically stopped because I just didn't have the energy to do it anymore. Then they told me, well, you got to work out, you got to do these things. I started lifting weights and I started running. I run 8 miles a week, and I lift every day. Every day I try to get up and lift, and I'm back doing. I did a 65-mile ride Saturday. I did a 40-mile ride today. I'm back doing 100 miles a week, just as if I back before, because it seems like the more energy you have, the more you work out. The more you work out, the more energy you have. So it's
Oh,
very repetitive.
thank you. We're going to go to Alan, and then I'm going to close it out with Peter Kafka. Go ahead, Alan.
Yeah. So I was really fortunate when I went on the hormone treatment because I was a rock climber and I climbed with a bunch of young kids and they just pushed me to, use my muscles, and then I lifted every week to build my muscles up. And after listening to Jimmy talk, actually I've been pushing myself harder. Instead of doing just one climb, I do two in a row, just like the young guys maybe do 3 or 4, but I do 2. And I push myself until I just can't do any more. And I think that's got me through the hormone treatment. Mine was just luck, but that's what got me through. It was the rock climbing. Yeah, I did the walking, I did the running, I did, but that's what really kept my muscles up. I'm really thankful for that.
Okay, I'm slipping one more in when you say that. But because let me just say, Alan is in his mid-70s. Now, this next gent is not as old as that, but if you want to hear about achievements on hormone therapy, Mr. Boardman, would you just like to give a very quick uh,
Yeah,
resume?
well, not now that you've embarrassed me, but no, things can be done. We went and climbed some really big mountains, like 22.6 and that kind of thing in Aconcagua. But the thing that I would mention is the depression is conquered by the exercise.
Yes.
As the folks who have been around here long enough know, for the last 7 years, I've showed up and I'm Eeyore. Oh, hell, everything sucks. Well, last October, I tried to pull myself out, and my internist said, I've been telling you for 6 years, if you walk every day for 30 minutes, you'll feel better. And I'd blown up like a tick, as we say in Wyoming. I weighed 206, and I've lost 30 pounds I lost 30 pounds by January, walking every day 30 minutes. I'm going to start the lifting. That sounds good because now I look in the mirror and I'm like a scarecrow with a pot belly, but at least I lost the 30 pounds. And so it is critical. I've been on Aberone and Lupron for 7 years straight, or six, I guess 6.5. And that's another thing we can talk about, but thanks.
Okay, well, Peter, I'm going to let you close out with Al, and he needs a mentor, Peter.
I know we talk, we get together. We're pretty. Al, the one good thing that I have to say about Kaiser is that they pay for your gym membership. So I mean, you can get a free gym membership from them, which is not true with HMSA. So I would drill down with them and get it. There's probably a gym in Kihei that will follow the Kaiser plan. And the other thing is, I would strongly suggest you try to get an appointment with Dr. Hartstark, um,
Yes.
because and ask her this question because she has your record. She'll see your blood work from Kaiser because she can read all that stuff through the portal. And she might have some other ideas about other drugs other than abiraterone in your case that might be less affected by your liver or have less effect on your liver, which is an important consideration. So I would try to get a second opinion from her. She's probably not going to go too far from your present oncologist because I don't think Kaiser goes against their other docs, but she might have some insight into this abiraterone question.
Yeah, but we don't think that there's any liver issues, though. Al said there wasn't any. liver
Well, he said
issues.
his bilirubin was going up.
No. That was Bob. That was Dr.
Oh,
Bob who said
okay.
that.
Okay. Sorry, I missed
The
that.
blood
He does have to ask for a referral to Stark.
Right.
That's how Kaiser works. You just ask your doctor to give you a referral, and then you're in contact.
Exactly. And tell her that Ankan sent you, because she knows us very well. Okay? I've just put her information in the chat window for you. Al, it's right there. And the chat window are the two little boxes at the top. Okay?
Yeah, I got it.
We beat up on you a bit. I'm sorry, but we really want to get you better. By the way, has Kaiser done any genomic or genetic testing for you?
Yes, they have.
Okay,
They did
great.
that early on, and there was no genetic component to it.
Excellent. Okay. All right. I'm going back to my list and we're going to start running through everybody. And we're going to start with Mark Valens.
Hi. So I'm dealing with trouble peeing. And my whole journey began with complete urinary blockage while I was camping in a remote place in Mexico. Took me 8 hours to get to emergency room and get a catheter put in. And went back home to my urologist, and with a PSA of 1.2, he said, well, it's not cancer. So he did a TURP procedure. And they did a biopsy when they did the TURP, and my Gleason was 5+4. Anyway, so I went through ADT. Actually, had 3 years of it, but after the diagnosis, I had to wait 6 months until Mac Roach would do radiation for me, and I had 2 CyberKnife and then 26 IMRT sessions, and basically have done. That was 3.5 years ago. I've done really well since then. A year ago I went on an ADT holiday, and so but starting about a month ago, I started having trouble peeing, and so I don't know if it's left over from the radiation from over 3 years ago. They've The urologist has put me on Flomax, but it doesn't seem to be helping. I'm just looking if anybody has any other ideas what I should be looking for.
Anybody?
And you never had any surgery?
No. Well, I had the TURP surgery.
Oh, yeah, but I meant like a Da Vinci or something. Yeah.
No, it was all radiation.
And you were treated at UCSF, huh?
Yes.
Interesting. Because I went into urinary retention, and my oncologist wanted me to do radiation. The radiation docs wouldn't talk to me because of my urinary retention while I was on a catheter, and so I ended up doing surgery, and that fixed it. I used Peter at UCSF because I had a tumor in that was, in my prostate that was totally blocking me. And I've been good ever since, urinary wise, but it could well be that you got something still going on in your in there. I would consult with if you got a door into UCSF, consult with Peter Carroll or one of the top surgeons there, and just get their opinion.
Okay, the TURP procedure, which is a roto-rooter and cleared everything out. Everything was fine since then until, like I say, about a month ago.
What's
Mark,
your
did you ever
current?
have any scans?
I've lots of scans, never showed anything about that.
Because it sounds like your tumors don't produce PSA, or very
That's
little.
correct. They never did.
So they've done CTs and MRIs and they don't see anything.
Yep.
Hmm.
I just what I've read is that the radiation can cause urinary problems. It's just a little surprising that it didn't show up for 3.5 years.
No,
And
that's not surprising, Mark. I mean,
okay,
it can take 3 years. And what I
okay,
would do, I'd go back to Mac. He's pretty good on this
okay,
stuff, and say, Dr. Roach, I'm having trouble with peeing. I'm wondering, I got some urinary retention, and I'm wondering, my urologist here doesn't. Have they done any scans since you had this issue in the last 2 or 3 weeks?
trying to get into a urologist here is a 2-month wait, but I'm scheduled to get a cystoscopy.
Cystoscopy. So I think what I would do is tell Mac you're scheduled to get a cystoscopy. It's a long thing. Knowing Mac, he's going to say, "You come down here, we'll sort you out," and he'll set you up and da 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 da. And I think that's probably what I would do.
Okay,
I'd fire off. I agree with Len. Len took the words out of my mouth. Actually, I mean, we may need some more scanning. I don't know what type of scanning. Maybe some FDG scanning. I know your PSA is very, very low, which is a good thing, but it could well be some inflammation from the radiation, some radiation cystitis. I mean, my radiation cystitis didn't kick in for at least a couple of years, if not more.
okay,
And then I started getting a little bit of bleeding. It was never that bad. But everybody's different, and you may be getting some swelling there. And I
okay,
think that the man to talk to is Mac. It doesn't get better than Mac.
okay, great. Well, thank you guys.
Anybody else have anything before we move on?
Are you on a catheter now or again?
No, I just I got to get up 6 times during the night, and it takes me 3 minutes to pee half a cup.
Are you pushing on your gut to get something out?
Yeah, and I don't have
Yeah.
trouble during the day. It's just when I wake up in the middle of the night.
I mean, our situations are
Okay.
different because I had the surgery, but twice in the year after the surgery, I had to go back for general anesthesia surgery to reopen between the bladder and the ureter, right? I mean,
Yeah.
but yeah, 3 years, I don't know.
Okay.
Well, with radiation, it really does have that. They tell you, and you think, "Oh, that can't be," but it is. So,
All right.
all right, we're gonna move on, and the next person on the list is Julian.
Good evening, everyone. Just wanted to bring a quick update. Saw Dr. E last week, and it's steady as she go. My PSA still in the dirt. She just wanted to take up my vitamin D. So doing well and exercising, by the way.
We know. Okay, so everything's good. Your PSA is undetectable. What was your testosterone?
143. It's on its way up.
Okay, are you feeling any better?
Oh yeah, feeling better. But when I wake up in the morning, I feel kind of not with it, if you will. But when I go and work out, I'm a different person.
Okay. I hope Alfred's still listening there. It makes a big difference. We know it. Anyway, well, that's good. And how's Dr. E doing? Was she in good form?
Always in good form. She knows I'm an engineer, so she says, "Okay, how many questions you got for me today?" But she still got on top of her game.
Okay. All right. She sent me an email and she said she's a little she's not thrilled with this olaparib thing that's going on, because she did that trial with abiraterone and olaparib, and she thinks that there's more things that can happen, and we got to talk about it. I said, I'm ready. When you're ready, you educate me. So we've got to find out what she thinks about this. On the other hand, our BRCA doc absolutely agrees that olaparib isn't effective.
Yeah,
So
I'm also having physical therapy for my pelvic floor. I have a real good physical therapist. In fact, she wants to come on and do a talk on it.
well, we just had one. Tell her.
This is male, not female, Rick.
Oh, sorry.
I said we did one on female
No,
pelvic
the
floor.
one we did was male and female.
Yeah, I got most female out of it. I'm sorry.
Well, I think that's what was because that was the images, but it wasn't really. I think you need to go back and listen again, and it was male and very much male and female, and that was the instruction we gave them. But they can't put up female and male anatomies for every picture. But you go back and listen. You go back and listen again. I don't think we'll be running another one for a while, but we'll do another one. But it won't. But I want to encourage all of you. I mean, we ANCAN runs, I don't know how many, 30 meetings a month now. We have women and we have men, and we have a lot of people that need pelvic PTs, pelvic floor PTs. So we have to cater to both flavors. And I mean, we got other people complaining, oh, the men got shortchanged. But if you go back and listen, they really spoke to both. They were pretty fair, because I was paying attention to it, Julian. I really was. But I do grant you that the images were not equal. Just saying. Okay, Joe, if you can you put the pelvic girdle webinar link in the chat window? Thank you. All right, Peter Kafka, you got an interesting update for us.
Yeah, this does not apply to everybody because, as you know, I'm an odd duck. I quack like an odd duck, and I walk like an odd duck, and anyway. So as I mentioned last week, I'm on Keytruda, an immunotherapy, and I've got some intestinal side effects. I just did my 9th infusion on Friday, kind of reeling a little bit. Can't get too far away from the bathroom, but one of the interesting side effects that came up, and I talked to Dr. Bob G this morning about this, and he gave it a name. It's called Sjogrens, Sjogrens, apostrophe S. Anyway, dry mouth. And we know this with Pluvicto, but I didn't realize that it was a side effect of Keytruda as well, seems like. So it hasn't gone to my eyes yet. It's mostly in my mouth, but it's pretty heavy duty. And according to my oncologist, who I met with last Wednesday, he says it's not going to go away. It'll just get worse. And so everything tastes like a true sandwich. It tastes. I wake up, just with sand in my mouth, and it's pretty intense. And Dr. G gave me some ideas, and someone gave me an idea last week about Biotine mouthwash. And I thought and I went out and got that immediately, and that's been helpful. But I think I had a heads up on this early on. I think after my first or second infusion, I mentioned that I was starting to feel my neuropathy a little bit more. And I thought I was imagining it, but I don't think so. I think it's affected my peripheral neuropathy too in my feet. I can feel it a little more. Um, so I just want to report in. I'm managing it. I'm doing okay. I'm not bitching or complaining, and I don't think I'm going to go off. I think the trade-off is that the damn stuff is working. I don't know where it's going, but we'll see. I'm in here for the ride. But I just want to mention that if you ever have to take Keytruda or want to take an immunotherapy, there are some side effects that affect your autoimmune system. And you got to watch it.
How's your
Thank you.
PSA doing?
My PSA dropped from 2.8 down to 1.79 in 3 weeks just now. So it's heading the right direction. It's doing okay.
Okay.
So I'm responding to it.
Anybody else have experience on the call with anybody else gotten pembrolizumab or another anti-PD-1? Any other, that type of immunotherapy? Not Provenge because that works differently, but anyone else on the call who fits in that category today?
I don't think so.
I don't think so either.
Anyway, just mentioning it just as a interesting point. You
Anybody?
never know on this
Yeah,
ride what's going on.
I'm not on it, but that's probably in my future. So I've done a lot of research, and basically, it can open up almost any autoimmune disease, which is what that Sjogren's is.
Yep. Yep.
Thyroid. So
Yeah. I was going to say, I thought Sjogren's I know is thyroid, and I do know that that the anti-PD-1s do have an impact on your thyroid, Peter. That I do know,
Yeah,
but
I
I
know.
didn't realize that the dry mouth was an issue.
Yeah, one time my thyroid numbers went up and I had to up my meds, but I'm back down normal meds now for it.
Anybody have any other suggestions other than the biotin for Peter on the dry mouth? Any of our Pluvicto guys got anything to say for dry mouth?
Peter, this is Al. Have you tried the lozenges too? That
No,
was what worked. That's what worked best for me.
yeah, I'm gonna get some. Dr. Bob mentioned that the toothpaste and there's other
Lozenges, toothpaste,
yeah, right.
lozenges, spray. I mean, they got a whole series of products, but the lozenges are what work best for me.
Okay.
That's great. Those are biotin lozenges, Al?
Yeah, yes, they are.
Okay. All right.
So,
Do they
Rick, I
come
have
in
a,
different? Do
I
they
have a
come in different
question.
flavors? I'll come back to you, Len. Do they come in different flavors, Al?
I haven't seen any different. I haven't seen but one kind of box on the shelf
yeah,
at
Okay.
Walgreens.
it's just one flavor.
Right.
Okay. Thanks, Dr. Bob. Len,
Well,
please go
well, Dr.
ahead.
Bob mentioned something that he reinforced something. I mean, to stay away from sugar. So, I mean, some people say, well, chew on lifesavers or this or that, but he said that which is good information, that saliva helps fight tooth decay. Dissolve those sugars, and if you start taking sugar without saliva, producing saliva, you open yourself up for pretty advanced decay, and I don't want to
Right.
go there.
Thank you. Len.
Yeah, two questions. One for Peter, one for Bob. So, Peter, did Schultz tell you that once you have the Sjogren's, that it doesn't go away?
No, my local doc told me that. I haven't talked
Okay.
to. I haven't put Schultz in the loop yet. I'll call him.
Okay.
Send an
And
email
even
to
it,
him this week.
he said, even if you stop the medication, it still wouldn't.
Yeah, he thinks it's there for the run.
Yeah.
But then, Bob, my question to you is, they usually manage any of the autoimmune side effects of the immunotherapeutics with steroids. Would that help with Peter's case, do you think?
Yeah, Probably. I mentioned it to him, and he seemed a little reluctant to start getting into that. Um, I can't say for sure he has Sjogren's, but it certainly would make sense. Um, there is one artificial sugar called xylitol, Xylitol, and that's you can get that in like lozenges, mints or chewing gum that has that as the sugar, and that actually has been shown to help reduce cavities, whereas all the other artificial sugars kind of are neutral. You might find that in you might find that online. Doesn't taste great, but
Thanks, guys.
Peter, Peter, I have one suggestion for you, especially as it pertains to Sjogren's. Reach out and ask Alexa what she knows.
Sure.
She's very knowledgeable around thyroid issues. She's a stage 4 thyroid cancer patient, and
Sjogren's isn't thyroid. It's just I just said that thyroid is another issue that's common with immunotherapy.
okay. Sjogren's is an immunotherapy response.
It's an autoimmune disease.
Right. Okay. Okay. Well, I know I've talked to her about Sjogren's as well before because we've had people. I'm trying to think which group it's in, but we've had people in one of our groups that also have Sjogren's. So do ask her. Check with
I
her.
will. I need to talk to her anyway. Yep.
Okay. Sounds good. All right. We're moving along, and the next person up is Pat Martin.
Okay. Last Friday, I got infusions of cabazitaxel and carboplatin. In the words of the physician's assistant, she says this isn't acting like prostate cancer anymore. We're going to go real aggressive. So I got those started. I've got an appointment for next Monday to get a needle biopsy in my abdomen, see what they're dealing with. And the same day, I'm going to have a radiation simulation. So I have an idea. They haven't said it directly, but looks like I'm headed towards what is it? External beam radiation, and go from there. But what's kicked me down this go around is they give me something for my um, to encourage my bone marrow to produce white blood cells. It's Neulasta, and my legs are just killing me. I mean, it's never had it like that. Anyway, so that's
Have
my
you
update.
have you
I
ever
got a
had
few questions here. Hold on a minute, Joe. Let's first concentrate on the Neulasta. Who wants to talk to the Neulasta? Joe, did you want to talk to the Neulasta? Go ahead.
yeah have you ever had chemo before, like a docetaxel ahead of all this?
Yes, I have. I started
And
docetaxel in January.
did they
Uh,
do Neulasta with you? Because I mean, my experience is Neulasta is not a bad thing. It probably saved my life because like I did 6 rounds of docetaxel and my insurance company said, no, we weren't going to pay for the Onpro thing. Well, on round 3, my fever went up and my doctor said, you got to go to the ER and get 2 armfuls of vancomycin because we don't know if you're going to go septic or not. And after that, they decided, oh, we can afford the Neulasta, right? Because it was cheaper than the 3 nights in the hospital. And are you having a reaction to it, or why would
no,
why
they say it's a side effect. Pain in your
that
legs.
knock you down worse than the chemo?
Yeah,
Oh my
a lot
lord!
worse than the cabin. Um,
I'm sorry.
anyway, they say it'll last 3 to 5 days. So I'm 3 days into it. I can weather 2 more days, but it's odd.
Did they have you start taking Claritin or Zyrtec?
Yeah, they told me Claritin. I'm taking Claritin, Tramadol, and Oxy.
Oh wow.
So something should knock it down.
Has anybody else? I mean, we've had a lot of people use Neulasta in this group.
Well, just how about some Dex to get you up from the chemo, like
Yeah,
dexamethasone.
I'm taking 10 milligrams of prednisone, and I had an infusion of um, Dex when I got that was a preparatory drug. They give me that before I
So
got my chemo.
let me ask, Pete. We've had a bunch of people use Neulasta. Has anybody else had leg pain from Neulasta?
This is Dennis. I had Neulasta when I got my chemo, and it wasn't so much leg pain as my legs when I'd get up from sitting for a long time or get up in the morning, get out of bed. I felt like there were two telephone poles that I'm trying to pick up and move them. But that was the only thing I could attribute to my taking the Neulasta.
Al, you wanted to say something? Al Latimer?
Yes, well, I've had Neulasta 8 times, and I've taken it with Claritin, and I've had no problem with it whatsoever. So I guess it's back to everybody's different.
Yep.
Yep.
Let's
Sounds
just
like
move on. Let's move on from the Neulasta for a second, Pat.
okay.
So it sounds like they want to treat some of these pelvic masses they're seeing with radiation, is what you're saying, right?
I believe that's the direction they're going.
Right. I still feel quite strongly, if it were me, I'd want to get the results of the sequencing back before you charge into anything. And just make sure that you don't have something that is targetable. Now, when your physician's assistant says this isn't acting like prostate cancer, that's the very reason we said to you last week or the week before, you got to get these 2 lesions biopsied and let's see if we've got something that's starting to look like small cell. That was exactly that's the reason we encouraged you to do it. And that's the same thing that the physician's assistant is saying to you. So
and that's why they're taking a biopsy on May 8th.
right.
And
And
they're going to sequence it and take a look at it.
Okay. And so the sequencing and the morphology are 2 different things, right? You're clear on that now, right?
Yeah.
Okay. So the morphology, we definitely would encourage you to send the morphology to Epstein for him to take a look at.
Okay.
So you will need to tell him ahead of time you want Dr. Epstein to review the morphology. Those are the slides. The sequencing is a little different. Is the sequencing do you know where it's being sent to?
I think they're going to do it in-house.
Okay, the problem with them doing it in-house is it can take them 6 weeks. So you better ask them ahead of time. If they're doing it in-house, tell them no, you don't have 6 weeks.
Okay.
Okay? Because they are part of the old dream team, and they used to do their sequencing. I think they used to send all their sequencing to their dream team sequencing thing, and that took 5 or 6 weeks.
I see.
And if they can take enough that they can do that if they want, but you tell them I want this turned around in 2 weeks, which you can get.
Okay.
By sending to Tempus or sending to FMI, Foundation Medicine. But don't whatever you do, don't let them use everything for themselves. And then 2 weeks from now, they're saying, oh, it's going to be another month before it comes back. We need quicker answers than that.
Okay. Very
Okay,
good.
and be assertive. So so they'll respond to you. And so we need to check now. Are they going to check more than one site or just one site?
I really don't know. They haven't uh, been explicit in what they're doing.
I think you want them to be explicit before you go in there. And
Hmm.
if you've got two sites, have them biopsy both sites.
Yeah, I've got many sites.
Well, I mean, if you've got soft tissue sites that they can biopsy, I would have them biopsy at least a couple. Why? Because we learned the hard way with Herb, God rest his soul, that
Hmm.
neuroendocrine disease can show up in one place, but it may not show up in the other place.
Yeah,
And that's why we
that's
want you. Go ahead.
no go.
So the conversation you have with Schweitzer has to be, I want you biopsying as many of these sites as you can see because I want to make sure I don't have small cell. If I do, I want to know now, not 3 months from now.
Okay. Yeah.
And when you say you don't know, I think as a patient, you're entitled to know where they're going to biopsy. And
Hmm.
if you don't agree with what they're doing, you have to have a discussion with Dr. Schweitzer about it. And if Dr. Schweitzer says, well, we just need one, you say, no, we don't need one because we know your Dr. Nelson told us that neuroendocrine disease can appear in one site but not in another site. I want to check as many sites as I can.
Okay. I'll get an email out to them tomorrow. They love
Okay.
me.
they won't love you when we've driven them around the bend with all our questions, Mr. Martin.
Oh no, no, they've been very responsive. They've been
Yeah.
very responsive.
No, I mean, Michael Schweitzer knows us well, and I think he respects us, and frankly, this is their own research that we're recycling. And if it wasn't for Ben, I got to give a shout out to Ben. If it wasn't for Ben, we wouldn't have seen this. Ben found this piece of research from Dr. Nelson's lab at
Okay.
Hutch. So
Yep.
this is good stuff. Anybody else want to talk to Pat about what's going on?
So, Pat, if they're doing a simulation, that tells me in 2 weeks they're going to start radiating you. Like that seems like a
Yeah.
done deal to them.
I believe it is,
Okay.
and that's why I need to get with them again, um, and go from there.
Yeah, you've got 2 weeks though, because they do the simulation and then it takes 2 weeks for them to, prep and decide exactly how they're going to radiate you.
Yeah,
So,
and where and what and stuff. So
yeah.
no.
Yeah.
One thing I don't know if anybody, excuse me, on the call does know, but I don't know how small cell disease, if you do have small cell disease, I don't know how it responds to radiation. Does anybody know anything about small cell disease and radiation?
Well, other than I've heard you need to use platinum, so kind of no, right?
Well, you definitely use platinum for chemotherapy, but my question is, does small cell disease respond to radiation? Can you kill small cell disease off with radiation the way you can kill adenocarcinoma off with radiation? I would think so, but I don't know. I mean, Len or Ben, do you have any ideas, or Dr. John, do you have any ideas on that?
I don't have anything specific. It's just it's a um, rapidly dividing cancer, and that in itself should make it vulnerable to radiation. But I haven't heard anything specific.
I mean, I think that's a very good question to ask Dr. Schweitzer. if it were small cell, would it respond? Would the small cell respond to the radiation, Pat?
Good question.
Rick, this is Gary. I
Yes,
have
sir.
heard that it will in its initial stages.
Yep. So I have another thought for you, Pat. And if and this might be something that you want to raise with Dr. Schweitzer. There is a scan which is like a PSMA scan called NetSpot. And NetSpot shows up small cell disease. It responds to somatostatin. So instead of it responding to PSMA, it responds to somatostatin.
Huh.
And so if there is any somatostatin being expressed by these cells, it will see them. This was a scan we wanted Herb to do, but he was never in the right hospital for them to do it. And if you do have small cell disease and you do have somatostatin, then there is a treatment with lutetium for small cell. The name, I've just lost the name of it. It'll come back to me in a second. But it actually has been approved longer than lutetium, than Pluvicto. But it's a whole.
You think of Lutathera?
Yes, Lutathera. Thank you, Len. So if you were to show small cell, and if, as your doctor suggests, your PA suggests this ain't acting like regular, you may want to say to Dr. Schweitzer, Dr. Schweitzer, do you think it would be worth our while doing a somatostatin gallium-68 test?
Okay. I will.
And then the earlier they see it, the better they can treat it, and it responds very well to Lutathera, which is also made, by the way, by Novartis.
Okay.
And you're early enough that it might be a real interesting way to go, but you're going to have to raise that with Schweitzer and push him on it, and see if it might be worth your while. Now, if they were going to do that, you'd need to do all of that before they started radiation.
Okay. Very good.
Okay. So, and I'm pretty sure it's called NetSpot. I'm not 100% sure, but I can look later and I'll make a note. I can look later and tell you, but I think it's called NetSpot is the scanning. That would be like the equivalent of Illuccix or Locomets, NetSpot. And then the treatment is what Len said, Lutathera.
That is what it's called. I'll paste it in the chat.
Thank you. Thanks, Joe. All right, we got to keep moving, but we got some things for you to follow there, my man.
Yes.
Okay.
Come back to this and rewind it and listen to it.
Okay. I got to make my notes so I can do my notes later. Pat Martin, I'll just put NetSpot and I'll remember. And I must put also not Neurontin, the white blood cell stuff. What is it you're taking again? What's the name of that drug that's giving you the leg pain? Neulasta. Got it. Okay. I made my notes.
Excuse me, Rick. I looked it up. It said 9% extremity pain for Neulasta.
Okay.
And of course, more than that if you call it bone pain.
Yeah. Thank you, Dr. John. All right, we're going to Frank Fabish. Mr. Fabish, make it short.
Yes. Yep, I'm on.
Good.
Had a surprise follow-up with my doctor. I was expecting bad news, and it came out to be positive. My PSA went down from 1.14 to 0.12 instead of going up, which I expected. And we reviewed my CT scans and found out that the pancreas, the nodules in the pancreas are stable and not increasing, and have been that way for 3 years. The nodules in my lungs, 2 of them decreased in size by 50%. 1 of them disappeared. But the bad news part of it is that a new one appeared. But my doc wasn't concerned about it that much. He said because the new nodule is in the left lung and it's right at the edge of the lung and it's extending into the pleura. And he said that he thinks that half of it is in the pleura, that the liquid in the pleura may have forced its way into the lung to cause what looks like a nodule. And he wants to do another CT scan in 3 months with my next follow-up appointment and check to see what it does. He said, if I'm right, it will decrease in size or go away. If not, we'll continue to watch it. And if need be, we can do a biopsy to determine if it is prostate cancer metastasis. So all in all, he said, stay with the treatment, Orgovyx and darolutamide, no change, and see you in 3 months.
So what is causing the liquid? What's giving rise to this liquid that could be forcing itself into the lung?
He doesn't know why. It could have been an opening. It could have been something, he said, but it's just strange that a good portion of the nodule is in the pleura itself.
Okay.
And he said that indicates to him that it's not what the other nodules are like in the lungs.
Okay. Well, that sounds pretty good. Anybody have any questions at all for Frank on this? I said, Len's looks like Len's gearing up there. Len?
No.
Oh, okay. I thought you had something on your mind. Anybody have anything they want to ask Frank about this treatment path?
I'm just happy to see all those spots shrinking away.
Yeah.
Yes, that was very good news, and especially when they didn't go away after the chemo.
I guess I don't come off enough.
Right.
So my question is, what is your treatment path? Where are you at?
I'm taking the 2 ADT drugs. My primary is Orgovyx, and the secondary is darolutamide. And then 3-month follow-ups and scans as necessary.
I had an interesting conversation with somebody last week. Didn't really pertain to this call, this group. It actually pertained to a different one of our groups, but they were very concerned that if somebody was on a drug and they were also had some sort of a relationship with the company, that we made it very clear. So I just do want to point out that Captain Fabish here is an ambassador along with his wife for Orgovyx, and not that it has anything to do with what he's telling us, but in the spirit of full disclosure, right, Frank?
That's correct. And that's why I don't contribute much on Orgovyx, because of the limitations now, being the ambassador.
Okay. Well, Orgovix is one of our sponsors, Myovant, and by and large, we really do like that drug. And one of our, we don't do any sort of branded, but we tell the companies that if we like the drug, we say that we like the drug. So, for example, with Bayer, they say you can't promote our drug. We say, well, what if we really like it? We think it's a good drug. They say, that's okay. You can say that. So, Orgovix is another drug like that. And the one thing I will say that we're learning with Orgovix is it seems to be, which we always thought, it's easier to get on it and get off it. And the side effects are better. The big issue is getting it paid for, and that is on my desk to write to Maria this week, Calkins, and ask her about how we get more men onto Orgovix if they would like to be on it. So we're working on it. Okay, I keep moving along, and I've got 3 people left, so we're not doing too bad. We won't go that far over. First of all, Tony Fig.
Yes, I'd just like to give an update. I'm probably about 97% continent. I've been going to pelvic floor therapy plus doing acupuncture. And so it's been about 3 weeks, and I have very, very little leakage. The only time it seems to happen is if I'm hurling around a 40-pound bag of dog food, so maybe I need to switch to 2 20-pounders. But the physical therapist was excellent. She would ask what activities I'm doing or what movements I'm doing that might cause some leakage, and then I would explain that, and she'd give me an exercise to work on. So it really has been wonderful to be able to almost have complete continence back.
That's
And the
good.
other thing is, I was having trouble with my right hip, thinking that it was perhaps related to the hormone therapy, but I went to an additional orthopedic surgeon last Thursday, and apparently the joint spacing is almost non-existent now, so he's recommending hip replacement. So I've got to wait until I've got 9 more radiation treatments to go, and I've got to wait till my blood numbers come up, the hematocrit, the platelets, and red blood cells before they would consider doing any type of surgery. So that's about the update.
So, Tony, advice is only worth what you pay for it, right?
Right.
So, when you're ready and your blood counts resume, and you're considering getting a hip replacement, make sure you get it done anterior. You've got to look for a radiation oncologist that will do it anterior. Because
yes, that's what the orthopedic is. He's going to be doing it in anterior surgery.
Good, because I speak from peer experience, 2 hips, and the recovery is unbelievably quicker than if you have it from the side or the rear.
Mm-hmm.
And it's an easy surgery. It's not even like knees, and you'll fly through it. And we can talk more about it offline later. The other thing that I wanted to ask Dr. John is about these acupuncture points for incontinence. Anything to tell us about acupuncture points for incontinence or even for retention?
No, I don't know a specific treatment protocol. When somebody would come in for something that I was unfamiliar with, I would read up and develop a protocol for them and then use it. And if it worked, fine. If it didn't work.
Okay.
I talked to the radiation oncologist today about the return to continence, and he said in some cases the radiation does help to restore continence because you get some fibrous effect on the urethra, and it then requires less hydraulic pressure to retain or to stop any type of leakage. So there could be some contributory factor from the radiation.
Okay. All right. Any questions or anything you want to ask Tony about his great handling? And how long is it since your surgery, Tony?
9 months.
9 months.
And I'm 77, and I didn't believe that I would be able to be at this point. So I'm really very fortunate.
Fantastic. Okay, no questions. If no questions, we're gonna keep going. We've got Rob Glover, and then we're going to go to Cliff, and then I think we got everybody. But if we didn't, I'm willing to stay longer. Rob Glover.
Hi, good evening.
Good
Just
evening.
a brief update. After a bunch of delays and a snowstorm and delay, I finally started treatment. So I'm about halfway through IMRT radiation treatment. So just want to let people know. I started ADT back in November, Firmagon, with the idea that the radiation would start in February, but winter weather did not cooperate. So latest scans at the end of March for prep for my treatment showed no additional growth or changes that they could detect in my prostate cancer. So that was good. So right now we're just going through the treatment and finally got the ball rolling there.
Well, that's good. Now, this is SBRT to the gland and IMRT to the pelvic girdle. Is that what you finally decided?
Well, I think it's all IMRT, but it's 3 different doses. So it's I think there's 2 to the gland because like the Gleason 9 and Gleason 8s were all on one side, and the Gleason 7s were 3 plus 4s were kind of distributed throughout. So I think they're kind of doing a higher intensity on the problematic area, and then more general on the overall gland, and then a different dosage on the pelvic area. I forget what they call that.
And how many treatments all in all?
20.
20.
So,
Well, my guess is if it's 20 all in all, they've definitely got some high activity going on. But like I said to Pat, you do need to talk to them and find out exactly what they're doing. We encourage you to do that. Where did you decide to get it done in the end?
UC Health Cancer Center in Aurora, Colorado.
There you go. I was going to ask. Yeah, they got a good outfit.
And I know that Joe wants to know where you live in Colorado.
I live in Alamosa, down in southern Colorado. So,
okay.
That's a nice
takes me about 4 hours to get up here to the Denver area.
And then you stay.
Long drive, but it's worth it to live in Alamosa, man.
It's rough getting used to the traffic here in Denver.
And you're staying with friends or family or something whilst you're up there?
Hotel.
Okay.
Thanks to the American Cancer Society, they have arrangements with Extended Stay America for free hotel nights. So
great.
That was kind of a nice benefit that helps out.
Okay. Yeah, I haven't heard that. So that they're free. Did you say they're free?
Yes, American Cancer Society will do it. You're allowed up to 4 reservations, and each can be up to 5 nights, and it's pretty much free. They actually charge you $1 a night on your card, and then they credit you back.
Wow.
I'm
And
like, you don't really have to credit me back the $5 for the week.
which hotel chain is it?
It's Extended Stay America, so you
Okay.
get slightly more than what you pay for.
Okay. But that's really good to know. Not just for you. It's good to know for everybody. So that's
Yeah,
very helpful.
I can't afford to spend 4 weeks at a retail rate hotel, so
Right.
this has been really
And
helpful.
that's a great find. Rob, are you exercising every day, walking 30 minutes or
No,
so?
I am not, and that is one takeaway I have from tonight's call. I am not doing enough of that, and yes.
Okay, so
So,
especially you've been through half the treatment, it's going to catch up with you. The fatigue's going to catch up with you, okay?
yeah,
You've got to walk every day after your treatment, at least 30 minutes, and get that heart rate up, because that will help with the it's killing bone, but the treatment will kill bone marrow. You can't help, it's the radiation. But if you are boosting that every day with your walking, you're going to combat the fatigue. Okay?
yep. Thanks.
All right, and not to mention the weight resistance for the HT and everything else. Do they, with this extended stay, do they have a gym?
Well, they have 3 machines. They treadmill, an elliptical, and I forgot what the third one was. I don't know. I didn't recognize it.
Well, the elliptical will do you fine. You can do it on the elliptical, and if they've got any weights, use a few weights too.
And Robert, I sent you a direct message here in the chat about, I've been at UC Health for a long time. So if you want to text me or email, I put it in there.
Oh, I appreciate that. Yeah, I've so far I've appreciated the folks up working with at UC Health. I mean, seems like a good place and very responsive, unlike the previous doctors that some of the team here had recommended second opinions, and now every time I talk to somebody, I recommend second opinions.
I'm glad we leaned on you to get the treatment where you're getting it.
I appreciate it. Thanks.
Okay, anyone else before we go to Cliff to close out? Okay, Cliff, you're up, my man.
All right. Just recently had a CT scan and a bone scan since my initial diagnosis. Bone scan was negative as was before, and they say my lymph nodes are shrinking, are getting smaller. So that's pretty much it.
So let me just look here. I gotta remind myself. So, where were remind us where the lymph nodes were that were giving you grief?
One was in my chest, right up here, and one was in my abdomen.
Okay.
And they removed one from my abdomen.
Okay.
There were
So,
3. Now there's two.
okay. So, and they appear to be getting smaller, which is what happens when you take the hormone therapy. That's what's supposed to happen from the hormone therapy. I mean, they can be radiated too, but that's what's supposed to happen from the hormone therapy.
Right.
Okay.
That's pretty much what's going on now. I feel great. Have no problems. just moving along through life.
Cliff, did you say they surgically removed a lymph node from your abdomen?
Yes, they did a needle biopsy and it was inconclusive, so they went in and did a biopsy and removed one of the lymph nodes, and that's when they diagnosed the prostate cancer.
Oh. So that was one of the first treatments you had.
Yeah. Mm-hmm.
Okay.
Yeah. Yeah. Very interesting. And I see that that Joe Blanchette is already picked up on the extended stay. Mr. Glover, you can see if you look in the chat window, he ain't going to be paying them $200 again. So there you go.
Just as an addition to that, if you've used up your 4 loud reservations, they do give you 45% discount on the nights there at extended stay. So you can use the 45% discount anytime.
All right. Just remember, this is Ancan takes 10% of all savings. Just letting you know, you know.
And I don't think I brought it with me to the hotel.
Yeah.
But you got to reserve it through American Cancer Society, not through extended stay.
Okay. Thank you. That is great information. Thank you so much. We'll be using that again. I'm pretty sure. That is great information. All right. Anybody else have anything else they'd like to talk about before we close out? We're only 12 minutes over, so that's okay. But they're dropping off like flies.
I'm just glad to see you all. So nice to
We're
see
glad
you.
to see you. I wish you'd come in early, and then we'll schedule you because we all want to. Everybody who's waiting to hear about psilocybin, but I don't want to do it now because we've lost half of the people. I sent you something today on psilocybin.
No,
I
read that was good research, and it fits with what I've read.
Okay, you can thank Ben for that. That came from Ben. So, all right. You're looking quite well there, Mr. Boardman. Okay, we love to see you. All right, everybody, that's it. We're closing out at 7:13 my time, and we'll see you all next week with Peter back in the hot seat. Good night, everyone.
Good night.
Good night.